Telemedicine is one of the new frontiers in healthcare. It's underutilized, and really there's not enough education about it. It's one of the methods in which it's going to really improve provider and patient interaction. Today's presentation is really to talk about ways that we can achieve revenue for telemedicine services and improve overall patient satisfaction. Now, it's kind of interesting how CMS is sometimes at the forefront of developing payment policies for procedural services. Medicare usually sets the guidelines, the private carriers follow suit, and then they adopt and implement whatever it is that Medicare follows. With telemedicine, it's kind of the opposite. Medicare covers it rural, private payers will pay across the board. So private payers are ahead of the curve when it comes to telemedicine. Interesting facts, PricewaterhouseCoopers recently released an analysis this year, it was in April, stating that in 2015 there's going to be a 6.5 increase in overall healthcare costs in this country. That's a substantial increase for next year. Now, the American Medical Association, in regard to telemedicine, said that 70% of doctor visits today can be addressed via either a telephone or a video conference, substantiating the need for telemedicine. The American Medical Association also published another analysis saying that 97% of patients that needed care and actually dialed up received that 97% of the time. They did not have to wait in a waiting room, did not have to go through some of the processes that we have in a brick and mortar type of office. Today's presentation is really to discuss telemedicine. What is telemedicine? How is it defined by CMS? How is it followed by Medicaid and the private carriers? The provider role. So to understand how we can generate revenue and be conclusive with telemedicine, we have to understand what the provider roles are when it comes to telemedicine. We're going to talk about Medicare policies, Medicaid payment policies, and private payer guidelines. We're going to talk about which insurances are actually paying for telemedicine today and how you can take advantage of that. Provider documentation. We're going to talk about documentation and then regulatory compliance, the fun part. So what is telemedicine? How is telemedicine defined by CMS, and what does telemedicine consider a covered service when it comes to this type of service? So telemedicine, as CMS defines it, is a healthcare that is a delivery method where there's no patient-to-patient interaction face-to-face. It's over a video, a telephone, or some other electronic format. It's either real-time or it's by sending clinical information on the patient to provider. Three main telemedicine technologies that we're going to discuss: live interaction, store and forward, as some of our teleradiologists do, where they receive radiology reports, and remote patient monitoring. So glucose monitoring, cardiac monitoring, these are ways that telemedicine is used today and increases patient satisfaction and overall patient care. So let's talk about provider telemedicine roles and technology used in telemedicine. Let's talk about the patient interaction with the provider and the different medical settings. So remote patient monitoring can happen in the ICU, in the ER, almost in any place in the inpatient hospital setting. Now, it can also happen at home for the management of chronic conditions. A personal anecdote, my mother's a diabetic, and she has her endocrinologist receive direct feeds of her glucose monitor daily. So that improves her interaction with that clinician and overall gets her lower costs in healthcare and better treatment. Live video teleconsultation. This can happen in a variety of digital telecom type of ways, and it is reimbursed, and we're going to talk about coding and reimbursement for that. This can happen in the outpatient setting or inpatient. It's a very powerful tool to leverage and gain from it. Store and forward. This often happens in a low bandwidth type of scenario. It can be still images such as an X-ray, an imaging report, or any type of ophthalmology report. It's best used in dermatology, ophthalmology, and radiology. It's a highly efficient way to examine patients' imaging. So we've talked about technology involving patient care and how that interacts with the provider. Let's talk about two patterns of telehealth. The first one is when the referring provider gets that patient and determines that there has to be a consultant provider. You have one physician who's referring, the other one that's a consultant. Now, the interactive mode of delivery is whenever there's a referring, the referring goes to the presenting provider, and then the presenting provider has a live interaction using camera, audio, or video with that other consultant specialist. This is the way that the live interaction is going to work when it comes to telemedicine reimbursement and telemedicine coding. So I spoke a bit about the referring provider, but the referring provider really is the one that performs a face-to-face visit with that patient. He's the one that's going to determine the need for subsequent steps in that patient's overall management. Now, he develops the media presentation, and that goes to the consulting provider. Now, the presenting provider has a face-to-face visit and actually introduces that patient to the consulting specialist. That's actually when they're going to have a live interaction, and that's when the patient is going to see their consulting provider via telemedicine. At this point, the coding happens based off of the appropriate medical service provided and with the appropriate medical modifier for that encounter, which is GT, whenever something happens via video conference. Now, the consulting provider is a provider that receives that patient via telemedicine, and he's going to have to bill for his procedural service, which is going to be reimbursable. Again, he's going to bill for the appropriate covered CPT code, and he's going to also apply the GT or GQ modifier depending on the type of patient interaction that he has via telemedicine at that point.
Let's say it's all GT.
Yeah, it's easier. So, Medicare telemedicine policies. In the beginning, I kind of mentioned how Medicare seems to be behind private carriers in not only policy for telemedicine, but also adjudication guidelines and overall coverage for beneficiaries. Now, it would make much more sense for Medicare beneficiaries to have much more access to telemedicine services, but the opposite is true. Private carriers are much more accessible to their beneficiaries when it comes to telemedicine services. Live video is the only form of reimbursement that Medicare will issue. Now, the originating site has to be in a rural, health professional sorted area, a county outside a metropolitan statistical area, or in a federal telemedicine demonstration project, as is currently happening in Alaska and Hawaii. Now, the type of originating site as defined by Medicare for reimbursement purposes has to be either a doctor's office, a hospital, or a federal qualified health center, a hospital-based renal dialysis center, or a skilled nursing facility. For Medicare reimbursements, the originating site has to be one of these approved locations to be in compliance with the regulation. Providers who may receive reimbursement for Medicare for telemedicine include physicians, nurse practitioners, PAs, nurse midwives, clinical nurse specialists, clinical psychologists, and clinical social workers. As defined by Medicare, all of these staff are eligible to be paid for telemedicine services provided to Medicare beneficiaries. In the state of Florida, we have 31 rural counties. For all of these counties in yellow, telemedicine is covered by Medicare. So you can be in Miami-Dade or Broward, but your patient is in Monroe. That would be a covered service because that patient resides in an area that is considered a rural location based off of the 2010 census. And that's the latest information. I'm going to make a copy of this and everybody's going to receive this digitally, but this is important to note because when we talk about Medicare covered services for telemedicine, it's important to know where is that patient situated. This is what's going to determine how Medicare adjudicates your procedural service for telemedicine. Now, if it is in a rural location and you've properly documented and provided the service to that Medicare beneficiary, there's a slew of services that are covered, such as teleconsultations, office visits, follow-ups in the hospital or skilled nursing facilities, follow-ups in the subsequent hospital care. Now, the hospital care, there is a caveat. It's only one every 3 days. Or skilled nursing facility subsequent care, one every 30 days. individual psychotherapy and group behavioral health, individual and group diabetes self-management courses, and smoking cessation. Smoking cessation was included as a telemedicine service in 2013, and that's one that is a covered service for Medicare beneficiaries. From a coding aspect, we have more than 50 codes that we can select for CPT purposes, which would be for telemedicine services or can have the GT modifier associated to have Medicare pay. Now, notice some of these codes are with a G, so these are for telehealth consultations in the ER. More basic things like office outpatient visits, so you have your same coding structure. What's going to change is the GT modifier, where you let Medicare know that this is a service that was provided via telemedicine. Okay, so you're using telemedicine to see your patient. Everybody's going to receive a copy of these. This goes into detail about all the procedural services that are covered and what are the associated codes and descriptors, so you can see what are you performing and how should that be coded. So the codes have to be built with a modifier GT for video conference to establish that. And payments will happen to both the distance site provider, so where that patient is in the rural location, and also to the consulting provider. So there will be 2 payments issued for a Medicare telemedicine service. So
does the one in the originating place have to use the GT modifier since he's doing face-to-face visit?
Well, he's going to bill differently. He's going to bill with the code Q3014, which is for a facility fee that Medicare is going to process for having that patient in the office. Reimbursement is roughly $25 for having that patient there. The consulting provider is going to bill and be reimbursed 100% of the Medicare allowable for that procedural service when it has a GT modifier. So there is no payment reduction for performing a telemedicine service. Usually Medicare, when it's any form of reduced care, they're going to try to cut the payment, but with telemedicine, it's 100% with the GT modifier, and there's not a reduction in reimbursement. So let's talk about Medicaid. CMS has really allowed all Medicaid programs by state to dictate the way that they are going to reimburse telemedicine. So needless to say, it's created a lot of confusion with the Medicaid programs because they differ greatly as to what's going to be covered. Let's talk about Medicaid coverage and what ACA, the Florida Medicaid, actually stipulates. So I talked a little bit about the confusion that it says when you let every state make their own determination. 44 actually pay for live video. 10 reimburse only remote patient monitoring. 7 have partial store and forward reimbursement. And 17 reimburse for transmission facility fee. The fee that I just mentioned is roughly $25 with Medicare for having that patient in your office. Reimbursement policies vary by state, and I can tell you there's a huge difference between what Georgia will pay and what's actually covered in Florida. Georgia is one of the more lenient ones when it comes to telemedicine. So for the purposes of telemedicine reimbursement, Florida Medicaid actually considers the Medicare guideline the definition for telemedicine services. Now, only physicians can provide and be reimbursed for telemedicine services, meaning that a PA cannot bill, an NP cannot bill for telemedicine service through Florida Medicare. That's a big difference as compared to Florida Medicare. Now, the originating site does not receive that $25 payment that I just mentioned. The originating site with Medicaid does not receive any payment. That's a big hindrance towards getting the PCP to want to include that patient for telemedicine. Now, if a separate procedural service is performed, so let's say the patient came in for an evaluation and also had their vaccinations administered or had another workup, that, if it's separate to the telemedicine service, will be payable. That's the only way that the originating site can generate any revenue from that patient interaction. Now, the only codes reimbursed for telemedicine purposes when it comes to Florida Medicaid are your consultations. So they'll pay codes 99241 through 45 and 99251 through 55. So if it's a patient consultation, they will pay. If it's another type of evaluation, it will not be covered. However, if you have a referral, if you do the regular workup on the patient, then it can be considered a consultation based off of the Medicaid guideline. Now, Medicaid does not mention a rural stipulation or any HPSA requirement, meaning that independent of where the patient is, Medicaid will cover a telemedicine service for their patient base. So Medicaid does not make that requirement. As Medicare, they actually let you perform telemedicine services for rural locations. So commercial carriers are really ahead of the curve when it comes to telemedicine. They have much more policies that allow telemedicine and make the care much more accessible to their patient base, which improves costs and improves patient satisfaction. We've actually determined that the private payers are embracing telemedicine much more. We've verified that United Healthcare, Aetna, Humana, Florida Blue, Cigna, and WellPoint, among others, are today paying for telemedicine services and are not following the Medicare guideline for the rural location. Now, if you have a patient that participates in a Medicare Advantage program, then that plan is going to follow Medicare guidelines. But if you have an HMO patient, a private pay patient, then that patient will be covered as far as telemedicine guidelines are concerned. So these payers have actually published regulations and policies for the reimbursement of telemedicine services. Provider documentation. This is one of the key areas for any service provided to a patient, because as we know with telemedicine or any other new form of healthcare delivery, the insurances are going to not only review medical documentation, but more than likely scrutinize it more closely, because they want to make sure that if they're reimbursing for a medical service, that it's been properly performed and documented in the patient note. Now, anytime there's a telemedicine encounter, the telemedicine documentation does not differ from documentation from a face-to-face encounter. You have to follow the same standard when documenting a telemedicine service as you would if the patient was in a brick-and-mortar office. That documentation does not change. Always remember that anything that you do with that patient must be included in the medical note. That will be used for coding purposes, so it has to be clear for your coder, and also may be used in the point of a review if the insurance requests any form of medical documentation. Do not assume anytime that anything is left ambiguous or vague. It's not good, because it gives the insurance another opportunity to scrutinize the medical encounter and initiate recoups or prepayment reviews. You have to make sure that anything provided to the patient as a medical service is properly documented and substantiated in the medical record. So, guidelines to remember. A new patient is eligible for telemedicine services. You just have to document all the workup as you would for a new patient. However, it is a covered service. Medicare, Medicaid, and private carriers allow for new patients to be eligible for telemedicine services. So it's important to know what is a new patient and what is an established patient. A new patient is a patient you haven't seen in 3 years in your practice. An established patient is a patient you're currently working on and have seen within that same 3-year threshold. So let's review regulatory compliance for telemedicine. There's a few stipulations on here that differ from regular face-to-face evaluations or from having a patient in a brick-and-mortar office. Telemedicine, being a newer form of delivery of care, has a few regulations that differ. The first one is medical record authentication. The insurances want to make sure that medical documentation is being properly authenticated and is properly supported for the medical encounter and for the patient being reviewed. Issues regarding privacy and patient confidentiality. You have to make sure that any organization they're using for telemedicine complies with high-tech regulations and HIPAA for patient security and PHI. Rules and regulations. Different private carriers differ as to what regulations they follow for telemedicine services. It's important that you reach out to your provider relations rep or review the policies if there's anything in your contract that differs from the overarching rule for telemedicine. Now, HIPAA and telehealth. Telemedicine services have the same HIPAA requirements for security. So whether the patient is in your office, you're still responsible for safeguarding that patient's clinical information. That does not change. All transmitted data, whether it's a radiology report, any other type of medical record, must be sent via secure. There are severe penalties for losing patient information or from disclosing patient information when it should not be disclosed and it should be protected. So, closing thoughts. Telemedicine is really one of the new frontiers in healthcare, and there's not enough reimbursement happening for the Medicare payer. But the private care is really doing a good job of creating policies and enabling telemedicine for their beneficiaries and really making it accessible to improve the patient and provider interaction. If anybody has any questions, you can ask them now. Everybody will receive a copy of the presentation as well as a worksheet that lets you know, is a telemedicine service covered based off of the Medicare criteria? Yes?
Question. When the patient and you are interacting, if you don't do it, let's say HIPAA check, you don't know what that is. Let's say they want to send you something and they're not involved in HIPAA check. How do we do that? If they want to send it to my regular phone, that's not secure. If they want to send it to my regular email, that's not secure. Is there an email service that I can use that's secure as a doctor?
Yeah, there's I don't want to refer you to like Cisco or anything like that because that's personally what we use. But HIPAA chat, that doesn't give you the option to send or receive.
Yeah, but
You can
just
send and
invite
receive
them.
pictures, yeah, you
Okay.
can.
You just invite them to it.
Yeah, that should be sufficient. That should be sufficient.
My staff, just to give you like a practical example, is
Yeah,
okay,
please.
sorry, good.
I know because I've kind of tested the waters on this. So HipChat is something my brother actually created. He's an ex-Microsoft engineer. He saw me one time texting and doing a FaceTime call with the ER doctor, and he said, "Can't do that. It's not compliant." I said, "I don't care," just like probably all of you guys are saying. And he said, "Well, you should care because it's a $50,000 fine for you and a $1.5 million fine for your institution." So he said, "I'll write you software that is HIPAA compliant." I said, "Well, don't waste my time with anything that's going to take me more than one brain cell to learn or do because I won't do it. Neither will anyone else." So HIPAA is the closest thing we have to non-compliance. And it's really good because it's a free app, first of all, on the App Store and it can be used on any tablet or smartphone. It's on Android as well. We have a partnership with Apple. He has a partnership with Apple. So we don't really advertise the Android portion of it, but there is that. So we specifically created it to be exactly like we already use our phones. So texting, pictures, voice calls, audio messages, just like dictations and whatnot, and FaceTime-like calls. I say FaceTime-like because it's one button and you're connected via video feed. So it's really simple. Even my older Medicare patients can do this because they do this with their grandchildren already. So they know how to do it. Anytime I want to do an e-visit, for instance, I'm an ophthalmologist, so let's say I remove a lid lesion. I'm afraid of basal cell or whatever. So I send it to the lab. 2 weeks later, I need them to follow up, but it's a young professional, doesn't want to come to the office and sit in the office for 2 hours just to hear that their result was negative and they're healing well. So we do a telemedicine consult. So I will tell my staff to put them on the schedule in 2 weeks for a telemedicine consult or an e-visit. My staff will help them download the app, which is really simple and intuitive. It's just free on the App Store or Google Play. They will have the app. They will have a scheduled time slot, for instance. My staff, my tech, will get them on the phone just via the text and initiate like the chief complaint, the HPI, document those things. Then when they're ready, they will hand me like the office iPad or their smartphone or whatever. And I'll just come on the phone, do a quick like check of the lesion, which is just the eyelid, for instance, let them know their biopsy results, and we're done. 30 seconds later, they haven't taken a slot off of my schedule. They're happy because they're sitting at their office doing the telemedicine consult. And I'm happy because I bill like a quick 99213 or something like that with a GT modifier, and I'm getting paid 100% of my normal code. One second, Talia. Avisena, who's my billing company, did an analysis of my codes, and I'm being reimbursed on every single payer Medicare is the only one that I think that needs an originating site that's rural, but I did have one patient who was in Mexico, got a subconjunctival hemorrhage, which you guys probably know is one of the scariest things that a patient can have, but also one of the most benign. She called me from Mexico, and we did a HIPAA call. I saw that it was just a subconj heme, and she felt so much better. Her daughter wrote on Facebook how high tech we are, that we saved her a trip to the ER in Mexico, how she didn't have to cut her vacation short. I mean, really, it's a really cool perspective from the patients. And I was able to reassure her in 30 seconds that everything was okay. And then I got paid for it, which was pretty cool too. I wasn't expecting to, but it happened. And so that's the practicality of doing this kind of thing. Talia, what was your question?
How are you collecting co-pays?
Yeah, that's a good question. So I haven't performed any telemedicine visits with a new patient, but theoretically you can. They do cover the 99 codes. I haven't done it that way. I don't feel comfortable doing it, but some of you guys might. What I've done is, we have all patient benefits in our system in NextGen, and what we do is if they have like a $30 copay or whatnot, we have a credit card on file, and it's charged at the time of the visit. I have other patients who've met their deductible or whatnot, and there's no need for a collection. So you can do it however you want. I've also waived a copay on a few patients, so it just depends on how you want to do it.
Do you ask them to join HIPAA when they first see you, if they're not Medicare? Because Medicare is going to be very difficult to do this. And then the other thing for us, because we're interns, that whole copay thing is part of your, unfortunately, your reimbursement.
Right.
So if you don't start collecting copays, then that throws off a red flag.
Yeah.
So do you have anything that's written down that says, okay, you will get a bill for the copay, which obviously they will ignore, but
we don't like to send bills. We like to collect at the time of service, right? So, and Avisena does a really good job of that as well. But what we do is just keep it on file. And in my patient registration, I have a form there that says, hey, good news, we're now offering e-visits. And this is going to be great for you. If you'd like to, just download the free app and you'll be set. And then my staff initiates the visit and the call and whatnot. And the patient is aware of their copay. For instance, for under my health insurance, if you look at your own benefits, like I have a $10 copay for e-visits. And it's actually written there black and white, like they recognize it. It's Blue Cross and they recognize it. Also, my OMIC insurance covers telemedicine visits as well. So I'm being covered for it, and I'm able to bill for it as well.
And that's the right approach. As long as you let that patient know at some point that they're going to be financially responsible for any cost sharing, whether it's in the office or telemedicine, that's the right approach. Let that patient know what benefit they're getting from the telemedicine service, but also that financial responsibility is still there for any cost sharing that they may have based on the plan. Yes.
I have a question. I've worked for ambulatory surgery centers, and would this be reimbursable? Because there are some pain doctors, like a medical director who's an anesthesiologist that does pain procedures in an outpatient setting, an ambulatory surgery center, would do a consult in that setting. So can they bill from an outpatient ambulatory setting, not an outpatient hospital, but an ambulatory surgery center?
Any of the consult codes.
Yeah, any of the consult codes that fit the criteria for what he's performing in that outpatient, it's still an outpatient surgical center, right?
Right.
He should still be reimbursed. As long as the code covers the medical service that he's providing, it should be covered with telemedicine as it would if it was brick and mortar in the office.
This goes by your regular code, whatever you bills, as long as he has the GT modifier on.
Okay.
Remember that the main requirement for telemedicine is you're going to continue billing, coding as you would for consultation in this case. But by putting the GT modifier, you let the insurance know the patient wasn't here. It was via video conference. However, I still met all the criteria necessary for this evaluation.
So what kind of note do you have? Do you have to basically write like a soap note without physical? And
Well,
how do you document?
Well, the SOAP note is sufficient. You have to look at the code that you're billing. Let's say it's a consultation. You would have to satisfy all the consultation requirements for medical documentation. So it's going to vary by code. It does not vary by modality. Whether it's in the office or it's telemedicine, the documentation is still consistent with whatever is required for that code.
Yeah, usually for a code, sometimes you need 3 to 4 vital signs. So how do you get those? Or
Well, your code is not changing though. You would still need that.
How do you get
vital
that?
signs when the patient is over there in their office?
Well,
laying out?
yeah, that's part of the evaluation process where you have to see what's possible with the evaluation you're performing. I mean, it's not going to be the exact same thing. That's pretty, obvious. But the documentation standards are going to be the same with regard to whatever you're billing and performing.
Ronique was just saying, you actually don't need vital signs for like a 99213 visit. You just bill down, you bill your code down. One of the things that we have a partnership with Apple and HealthKit, which is their vitals monitoring program, is actually going to be essential for this too. So you will be able to get vitals through HealthKit eventually. But right now, you don't really need them for all the criteria to be met.
We're talking about the transmission of sugar levels. How do you code that?
Well, it would be well. The example I mentioned was my mother. She uses a glucotel, so that goes directly to her endocrinologist, and he would bill just a regular office visit when he gets all the information and it's time for her checkup. He's not there coding every time he gets a reading. He gets everything together, and then when he not sees her, but when he performs the evaluation, then he bills for everything that he has at that point.
Does he get in touch with your mother over the teleconference?
Yes.
Or,
Yes.
so she has to have an app on her iPad? Or
Yes, I believe that the glucotel thing already has one. But what it does is every time she checks her glucose, he gets it. So when he performs his evaluation, he has all of her history, let's say for the last 30 days. Sorry?
What's the glucotel?
It's a monitoring system. So when the patient checks her glucose levels, it transmits directly to the endocrinologist. He has software whereby patient it creates a chart and it says how that patient is improving, how that patient's sugar is spiking, and how everything is working.
Well, I just wanted to ask Avisena, because we're talking about, keeping patients' credit cards on file. I mean, what are the legalities about that, from a billing perspective? I mean, is there, people are going to say that, that's not legal to keep my credit card on file.
Well, we have a secure network where we keep all the patient information, whether it's financial or PHI. So losing patient credit card information or financial history, that would happen. We have a secure network for financial and for PHI.
And are there, are the co-pays less for a, chat versus just a regular office?
Well, it depends on the plan. It depends on the way that that's why I said you have to look at the different care policies, because the plan is going to dictate what your cost sharing is involved in telemedicine service.
But so my question is, like on hers, if her copay is only $10 and she's billing the same code and getting 100%, so the insurance company's actually paying more for a telemedicine consult than they are for an office visit.
Yeah, a lot of times, but their draw here is so their draw here, the insurance companies really like telemedicine because it's reducing the readmission rate for patients. And you guys know about that because let's say you have a patient admitted in the hospital, 30 days later, if they come back in the hospital doesn't get reimbursed for that first visit. That sucks, right? So insurance companies like you to keep the patients out of the hospital, and you like to keep them out of the hospital so that you'll get paid too. So they actually advocate telehealth because, let's say internists over there, you guys put a patient on a new blood pressure medicine, you need to see them in a couple weeks to see how they've been doing. You can verbally ask them how their blood pressures at Publix have been, and you can record that, and that's your telehealth visit. That's all you really need, actually. You can have them check for pitting edema, you can have them breathe deeply for you to make sure they're not wheezing, or whatever. I mean, you can do things on the video that will still qualify as a physical exam. You have to pick and choose. It's obviously not for everything, but it's been really valuable for me. I mean, just for quick follow-up stuff where medical legally you have to, close the loop on that subject or whatever. But you can save the patient a visit and save yourself a slot on your schedule.
Question.
More questions?
Do you keep that video of your interaction with the patient in the patient's chart somehow?
Just
Where
like
is that stored?
You don't need it. Just like when you're seeing a patient, Just like if you're seeing a patient, you're not being videotaped when you're seeing a patient. As long as everything's documented, you're fine.
So you basically enter your note as you normally would.
Absolutely.
Just stating this is over the video or whatever.
You don't even have to state it. You just put a GT modifier, and that's what states it.
Consulting physician, now it sounds like you just called the wrong patient. You know what happened to the office?
Well, yeah,
Sounds
that's
great to me, I mean, how will
yeah.
it work?
Well, that's going to happen when, let's say, a PCP needs for a specialist to review, and it's in a rural location. So they're going to actually get the patient to the office, call that specialist, and have the telemedicine. That's what I discussed there. There's different ways that patients interact with telemedicine. Yes, yeah. There's different modes of telemedicine. I mean, if you look at diabetes management, if you look at end-stage renal disease management, if you look at just primary care management, it's all different ways of managing the patient. We have cardiologists that all they do is look at cardiac vitals and things like that, and that's also reimbursed differently. So this is going to defer telemedicine based off of your specialty and based off of your patient population.
Does anybody have a specialty again? With a specialist, I think a lot of patients don't have a problem giving them their credit card. I get an issue every single time I ask for a credit card to be, on file. Like, I'm not gonna.
The whole people
I'm gonna go see another doctor. How dare you? What kind of doctor are you? I'm like, I want to pay my bills. What kind of doctor I am? I don't know.
Yeah, I think that's kind of the universal problem. But the way you mitigate that is by showing the improvement of medicine and how you can automate their transactions by including information on file that is something caution. I mean, it's about how you explain it, about how you show the value of having that upfront.
Yeah, I just wanted to see if anybody else had
Somebody always can
I comment on that.
somebody who's always smart.
Sometimes you have to use the argument of common sense because these patients have PayPal, they have their credit cards on file with American Airlines, etc. And you just have to kind of have that dialogue. And a lot of times when we try to have that conversation, they realize, oh, I get it. But unfortunately, medicine is one of the last frontiers of credit cards.
I know.
Right, exactly.
With my EMR system, I have a patient portal where a patient can send me an email, for example, describing their symptoms. It's secure and everything else. I receive and I respond. How is it different from telemedicine?
Well, hold on. Eddie, that's not. Can you give her the mic so we can hear the question? Yeah. Hold on.
For those of us who have EMR and patient portal, I receive emails through the secure portal system from patients, for example, asking me questions. For example, their blood pressure has been running high for the last week. I'm primary care physician. And through the patient portal, I send my response, which is also a secure way, saying that increase your medicine or cut the salt or see me in a week or whatever else I would advise it. Does that qualify as telemedicine or how is it different?
Well, that's different from one of the main modalities of telemedicine, which is live patient interaction. What portal is that?
It's part of the eClinical Works. It's a patient portal where patients can see their chart, their medicines, the last visit, what changes I have made, and they can send me questions through the email. And it's all HIPAA compliant and secure.
Now, does that save in the patient's record? Is
Yes.
that stored? Okay.
It saves as an encounter, telephone encounter, or e-encounter.
Okay. Then you should be able to bill as an e-encounter. There's a code for that.
There is a code
Yes.
for e-encounter. What's the code?
Yes, it's a 989. It's a range. I'd have to get it for you. It's actually in the presentation. I'll get that to you. But anytime they're having a patient interaction, and you're providing clinical expertise, patient management, there is something you can usually do. Okay, now I asked if it's included in the patient record, because if it's included in the patient record, if it's included in the patient record, then it's part of that clinical history, and therefore it's part of the management of that patient. So we can talk about that and see what are ways that you can generate reimbursement from that.
So for
Because you don't just
telemedicine, you have to see the face of the patient.
no, there's different ways. For example, I mentioned live video, which is the main one. It can be over the phone. It can be over a saved feed. So let's say I have a radiology report today and that gets transmitted to you. You can read that in your office. So there's different ways, but I'm sure you have something with that type of chat option that you have, so we can discuss that. Is there any more questions? Well, thank you everybody for your time. I hope you enjoy your meal. Thank you.
I hope you guys found this educational and very useful with, everybody squeezing you guys for time and for your money. I think this is an amazing way of increasing the amount of patients you can see without putting a big strain on your schedule. And I think Dr. Havas has done a great job at setting the example for everyone on how to make more money. And I also just want to recommend also... I'm sorry?
Yeah, let me correct you. That is not our draw here to make more money. It is just to make it more efficient and
Okay.
make patients happier. And to actually get reimbursed for things we were already doing anyway.
Okay, excellent. Sorry. Thank you. I want to thank all the sponsors again for their support, and please, oh, thank you. Thank you for, Michael at Savacity. Thank you for Citizens. Thank you, Willis. Thank you, Marnique and Carol at Northwestern Mutual. Thank you, IMD. Thank you, Marine Max. Thank you, HIPAA. Please visit. When we work with partners, we make sure that the partners that we work with have the same level of customer care that we do. It's all about the support. There's a lot of systems out there, but it's definitely about the support that they provide, and our partners definitely live up to that. So I want to thank you guys. If you guys have any questions, Eddie will be around, and you have our contact information. So if you have any questions, please reach out to us, and I'll make sure your questions are answered. Thank you.
Thank you, Miguel.